I'm Dr. Suresh Ramalingam, medical oncologist from the Winship Cancer Institute of Emory University in Atlanta. What is the optimal way to use immunotherapy in patients with mesothelioma? Mesothelioma is a rare disease. We're talking about pleural mesothelioma, where for a long time we have not seen any improvement in treatment outcomes. Majority of the patients with mesothelioma at the time of diagnosis are not candidates for surgical approaches because of extent of disease. Patients with mediastinal nodal disease or extensive local invasion are not candidates for surgical combined modality treatment approach. Now, when we think about mesothelioma, 2/3 of the patients have epithelial histology, a small percentage of patients have sarcomatoid histology, and the remainder have mixed histology tumors. We have known for a long time that epithelial histology is more sensitive to chemotherapy, whereas sarcomatoid histology is not. Until now, for patients with surgically unresectable mesothelioma, the standard of care has been combination chemotherapy. Almost 18 years ago, the combination of cisplatin and pemetrexed was compared to cisplatin alone and was shown to improve overall survival, and then became the standard of care. And this has been in vogue until very recently. A few years ago, anti-angiogenic drugs, specifically anti-VEGF therapies, were added on top of chemotherapy, and they showed modest improvements in overall survival. So in some parts of the world, chemo plus an anti-angiogenic drug is used for mesothelioma. With the advent of immune checkpoint inhibition as an important strategy in a variety of malignancies, there was natural interest to study these agents in patients with malignant mesothelioma. We now have at least results from 2 large randomized trials that clearly position immunotherapy in the treatment of mesothelioma. The first trial I want to talk about is Checkmate 743 trial. This is a randomized trial that compared the combination of ipilimumab and nivolumab to standard chemotherapy for first-line treatment of malignant pleural mesothelioma. This was a large phase 3 trial that was reported last year, and this study's results led to the FDA approval of EP and Nivo for frontline therapy. The trial showed that the combination of EP and Nivo was superior to chemotherapy with the extension of overall survival. Now, when we look at the outcomes based on histological subtypes, patients with sarcomatoid histology did particularly well with EP and Nivo compared to chemotherapy. The hazard ratio in epithelial histology tumors was still favorable for EP and Nivo, but perhaps not to the same extent as what we saw with sarcomatoid histology. So now this combination is an approved regimen. Now, when we use this regimen, one needs to be aware of the adverse events of EP and Nivo. This combination can have autoimmune adverse events, but thankfully, most of these events can be recognized early and appropriate interventions can be put in place so patients do not have to suffer from severe consequences. The incidence of grade 3 or higher autoimmune adverse events is relatively small. This regimen now emerges to the top of my algorithm for sarcomatoid mesothelioma as first-line therapy, and for epithelial mesothelioma, both the ipi-nivo approach or the combination chemotherapy approach are very reasonable. Now, for a long time, we did not have good salvage therapy options for mesothelioma. If a patient gets chemo in the frontline setting, we did not know what the appropriate second-line therapy regimen was. And several studies were conducted to look at various strategies, including CTLA-4 blockade, and these studies did not show improvement in outcomes. However, more recently, a study had showed nivolumab in the second-line therapy setting to be very effective. This was a randomized phase 3 trial reported by Dr. Dean Fennell very recently. And what he showed is, when compared to standard of care, the use of nivolumab in the second-line therapy was associated with improvement in overall survival. So if a patient gets chemo in the frontline setting, one could either use nivolumab as salvage therapy or even potentially consider the combination of nivolumab and ipilimumab. Finally, an emerging approach involves the combination of chemotherapy with PD-1 or PD-L1 inhibition in the frontline therapy setting. There have been 2 phase 2 studies, one reported out of Australia and the other one in the United States from PrecisCa. And in both of these studies, platinum doublet combination was combined with durvalumab. What we saw were very promising results with the chemo plus PD-L1 approach, and a very promising overall survival result, particularly in the North American study, PrecisCa study, where the median survival was over 20 months. So there is now a randomized phase 3 trial that compares chemo plus durvalumab versus chemo alone for frontline therapy of mesothelioma. So we look forward to these results to see which of these approaches will gain a strong foothold in the frontline therapy treatment for non-small cell lung cancer, for mesothelioma. The last question is PD-L1 expression. Does it matter? At this point, we don't routinely use PD-L1 expression to select immunotherapy treatment options, but there is clear need for better biomarkers in this setting. So the good news is combination immunotherapy approaches are effective in malignant pleural mesothelioma, and the ipi-nivo combination is approved by the FDA in the United States for first-line therapy.